Hi, this is Brian Kim. I'm going to share with you this case of a patient who has a Rezoom multifocal lens, which was placed 15 years ago. What's interesting is the patient put this lens in both eyes, but the patient was very unhappy, and the response that the surgeon had was, it's very dangerous to have the lenses removed, so you're going to have to live with it. So this poor patient, has had poor vision in both eyes for 15 years, and I've been following her. I mentioned IOL exchange to her in the past, but she's put it off. But then we finally decided, okay, enough's enough. She's been so frustrated with her vision. And I said, look, I think I can do it. I think we can do a good job. So I went ahead and exchanged this lens 15 years after surgery with an LI61AO lens in the ciliary sulcus with optic capture. So the first thing you're going to notice here is, number one, there's 360 degrees of overlap with the rhexis over the optic. And so that's very, very important. When I look at these patients in the pre-op and I'm making a decision on doing a lens exchange, that is one of the nice things about this. The surgeon did a good job and did a smaller size rhexis. So I have good rhexis overlap all the way 360 degrees around the optic. And why is that important? Because then this allows me easier way to separate the anterior and posterior capsules. And so I go ahead and make my incision first on the right side and then the left side. I'm making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. And I'll go ahead and inject some intracameral epinephrine. And this is the Fram IOL exchange capsule dissector. And this is from Epsilon. I go ahead and inject some dispersive viscoelastic through the cannula first, through the side port incision, and then I make my main incision, and this is a 3/0 blade. And then through the main incision, you can see this cannula is flat. It's got a little bit of a pointed tip, and I'm able to very easily get under the rhexis edge, and I'm pushing dispersive viscoelastic to, again, visco dissect the anterior and posterior capsules, and I'm sweeping side to side. The nice thing about this cannula, it's flat, like I said, and the port is face down towards the lens. You really don't want the port facing up. And this allows that nice separation. I'm able to go through the main incision and then now through a paracentesis incision. Now you'll notice this, as I encounter the optic haptic junction, there is some tough fibrotic material that's holding the lens to the bag in that optic haptic junction area, as you can see right here. But otherwise, it frees up pretty nicely, and I'm able to sweep all the way across. I had no trouble separating the anterior and posterior capsules, getting under the rhexis edge, and I was able to use a Fram dissector to very easily separate, dissect the anterior posterior capsules. And again, I'm just spending a lot of time making sure I'm able to really try to get underneath the optic haptic junction, trying to tease that apart as much as I can. But you know what? You'll see it's not that important that I get full separation, and that is because I'm going to place this new lens in the sulcus and then perform the optic capture. And so now I'm going to start working on the lens. I have a Lester in my right hand and a Sinskey on my left. I'm lifting the optic up at the optic haptic junction on the left side. And it's very important. See, I use the Sinskey to lift the optic up, and then I'm pushing. You see that? I lifted with the Sinskey, and then with the two-handed technique, I push the optic, slightly rotating it as I'm doing it, and I'm lifting it up. And the left side haptic, I'm able to dial that haptic into the anterior chamber. But again, I needed to have that left side optic up out of the capsule in order to be able to perform that maneuver. And you saw I did a two-handed technique to be able to achieve that. And once I lifted that up, the right side haptic just popped right out. Really, really easy. So this was executed very well without any problems, without much difficulty, not much capsular contraction. The zonules should still be good. And I also didn't mess with the cornea. All the maneuvers were away from the corneal endothelium. I go ahead and push some more dispersive viscoelastic to push that lens away from the cornea. And this is a two-handed microforceps and microsurgery technique. I use the serrated IOL holders to hold the lens and then cut. You can see I'm holding the tips of the scissors a little bit sideways, and I do that in order to be able to visualize the teeth and also making sure I won't cut the capsule as I cut all the way across. And I'm making sure I'm very anterior as I'm cutting very carefully so that I don't accidentally cut the iris or the anterior capsule. Use the scissors to push the lens off the IOL holder because, again, the serrated teeth, once you grab onto it, it's really sticky. It likes to hold onto the lens. I'm going to focus on the right side cut piece, grab it with the forceps, protecting the corneal endothelium and shielding it with the left side forceps as I pull that lens piece out. And I go after the right side piece because of the way the haptic is oriented, when I'm able to pull that lens piece straight out and the haptic collapses on itself. Unlike the left side piece, if I try to pull it, the haptic is going to scratch the cornea. You don't want to do that. So I'm turning it 180 degrees, very carefully making sure that I'm not near the corneal endothelium as I do this maneuver, grabbing the cut edge of the optic as I turn it, and then using the left side forceps to shield the corneal endothelium as I pull the lens piece out. This is some cohesive viscoelastic. I'm pushing cohesive viscoelastic to create space in this ciliary sulcus. You can see I have a really nice sulcus. There's no adhesions between the iris and the capsule here. The capsule is actually quite distended posterior here. And this is the LI61AO lens. Very carefully, I'm going to go ahead and make sure that leading haptic goes into the ciliary sulcus. I ask her to irrigate the surface, making sure that the haptic goes into the ciliary sulcus, going very, very slowly, because this is silicone optic. It can shoot out very fast, and it does right here. It shoots out. You saw that the trailing haptic was folded on itself. So I was like, okay, that's not quite the way I wanted to go in, but it went ahead and went in. But then this is what I noticed. The leading haptic, I'm not quite sure it's in the ciliary sulcus. Let me see. So I'm using the Maltzman, and now I start to realize the lens is descending. It's actually pointed and tilted down. So obviously the leading haptic is not in the ciliary sulcus. So go ahead and use microforceps to grab the lens, and then I went ahead and popped that leading haptic into the sulcus. And then using the Maltzman to dial the trailing haptic into the sulcus. And now I have a stable sulcus lens, a 3-piece lens. I'm going to go ahead and just remove that little bit of bubble there. And I want to optic capture it. Why? Because I don't want that lens to propeller in the ciliary sulcus. The sulcus is a much bigger space than the length of the haptics. So I use a Maltzman now to tuck the contra-incisional half of the lens. I tucked it under the rexus edge, and then I did the same thing in the sub-incisional half. So now it's in the optic capture configuration, which creates that cat-eye configuration of the anterior capsule. Go ahead and on low flow of the IOP, I go ahead and try to remove the viscoelastic in the anterior chamber. And I set the IOP low because I don't want such high infusion pressure, which will cause vitreous to come out of the wound. Now, part of the problem here is I'm using a sleeve that's smaller than the 3.0 incision here. And so in retrospect, I should have used a sleeve that's bigger, and I would have had less fluid egress. And you're going to see what I mean by that, because as I finish this case, I'm going to notice that I do encounter some vitreous. And so that's the other learning point here. If I'm going to be using a 3.0 incision, I should be using the irrigation and aspiration sleeve that's for that incision. The pink sleeve is really for anything that's below 2.6-ish. And then the purple sleeve is anything larger than that. And so I should have used a purple sleeve. But that's okay. I go ahead and use the bimanual vitrectomy mode here and start to perform vitrectomy. You can see it's not that obvious, but there is some vitreous to the wound. You can see right there, I'm going to sweep with my infusion cannula. It's very, very important when you have this optic capture configuration that you don't accidentally eat the capsule. If you do that, then you've basically sabotaged yourself. And so it's very important not to let that cutter get near the rexus edge. Now, in theory, with having optic capture, it should tamponade any more vitreous coming forward, because the lens in that configuration, the lens plus the capsule should be blocking any vitreous from wanting to come forward. Again, I'm trying to push down. You can see here I was pushing down on the lens in order to get those bubbles out, but also to try to remove any more vitreous that might be trying to come forward. And so that's another tip. You can kind of push down on the optic. And of course, since the optic is below the rexus edge, you should be able to push it down and then start to remove any vitreous, in that case, some bubbles as well. And then when you lift it back up and you don't put any traction on the lens will push back up and then seal off that vitreous against the anterior capsule. So you can see here, once I'm done with the vitrectomy, I push BSS before I come out with the infusion cannula, and then I quickly hydrate the incisions. And this should be the end of the case. And so this is a patient who, again, has had a 15-year Rezoom lens, is completely miserable with her vision. The other surgeon told her it's dangerous to have a lens exchange. And probably during that time, 15 years ago, maybe that was true, you know. But now with the advancements of our techniques, especially with the experience that I've gained over the years, I told her, you know what, I feel confident that we can do this. I go ahead and remove that lens. I use the Fram IOL exchange cannula, which worked very well in this case. I used dispersive viscoelastic to visco separate the anterior and posterior capsules. I was able to very carefully get underneath the lens using a two-handed technique with the Lester and the Sinskey. I was able to pop up the distal optic, tilting it up, and then dialing the left side haptic out of the bag. And once I did that, I was able to pop that right side haptic very easily. I did not have to separate the haptic from the lens because I just pulled it out of the track that the haptic was in. There's really no need to do extensive separation. All you're going to do is cause zonular damage, right? And so I was able to just slide it out of the tract that that haptic was in. Since I'm placing the lens in the sulcus performing optic capture, there's really no reason to do that extensive dissection. Once the lens was up into the anterior chamber, I cut it in a two-handed technique, being very mindful in the technique of allowing the haptic to collapse on itself, turning the left side lens 180 degrees in order to do that, protecting the corneal endothelium and shielding it with the other forceps on the left side as I pull the lens piece out to protect the corneal endothelium. And then placing this lens in the ciliary sulcus, you saw that the leading haptic did not go in. I used a microforcep to pop it up and then dial it into the sulcus and then optic capture it. You can see that this patient had a little bit of vitreous, which was found with the Wexel sponge. And then I go ahead and do some more vitrectomy. And then I place a tenon suture over the main incision. I always do that in these cases because you never know, and it can cause vitreous to come forward. I want to tell you something. I saw this patient in the clinic post-op day one. I had no idea what to expect. And as soon as I opened the door, she literally jumped on top of me and gave me this giant bear hug. And she told me this is the first time in 15 years that she can see clearly. I was so excited for her. I was just overjoyed that she was doing so well. And you know, this is why we do these cases. This is why we take on these challenging cases. Because number one, if you don't do it, who will? Especially in our area, Northwest Georgia. I wanted to make sure that I could serve this community in this region with the best of my ability, with the skills that I have, in order to be able to help these people versus tell them, you know what, you're going to have to live with it, which this person was told 15 years ago. She was so elated with her vision. And that's the other thing. It's such a rush when you're able to tell a patient that you can fix them and they've been so sad and just frustrated with their vision, and you're able to go ahead and take that lens out very carefully and then put a new lens in, a brand new lens, and this patient's saying that this is the best she's ever seen in years. Thanks so much for watching and listening. This is why I do this every day. and this is why I love doing what I do. And I hope you learned something new with this case. I hope this was helpful to you, and I thank you for your attention.